Hi, everybody. My name's Dorothy Henneveld, and I want to introduce the panel.
I'm Denise Klesick, and I am the program supervisor for the Coaching Families and Step-by-Step programs at Catholic Social Services, and worked as a frontline mentor in coaching families for about 5 years.
I'm Audrey McFarland, the director of the Lakeland Centre for FASD.
And I'm Tracy Knowlton. I've worked as a mentor for 5 years here with the Lakeland Centre for FASD and have recently taken over the program as program supervisor.
Today, mostly Audrey and I are going to be speaking about the mentor experience, mostly from an Alberta perspective and our own sort of experiences managing mentorship programs. We're first going to cover what the purpose of today's session is, which is an overview of FASD mentoring and its history in Alberta. We'll use examples from urban and rural setting to illustrate the importance of partnership and adapting to existing environments. And we're going to share stories of encouragement and hope. Do you want to speak to the learning objectives?
Oh, sure.
Yeah.
We're going to go back and forth a little bit, and we haven't actually presented together very much, so we hope it's not too disjointed for all of you listening. But today we're going to cover, as Dorothy said, the mentoring experience in Alberta. We're going to learn what a mentor does, and we're going to learn about the factors that contribute to the success of the individual mentors and the programs. And we're just going to share a little bit of information about what's happening across Alberta in mentoring and across Canada as we know it.
I want to encourage you to write your questions down because we really would like to have a dialogue towards the end of the session. So make sure you jot down your questions as we go along. Audrey and I are going to speak a little bit more specifically of our programs, but first we wanted to do a little bit of a description of the PCAP model, which is the Parent-Child Advocate Program out of Seattle, Washington, which in many ways is kind of the mother, the beginning, established sort of what mentorship is really about. And in 1991 in Seattle, Washington, the Parent-Child Advocate Program began. It's an intensive 3-year-long paraprofessional home visiting program for the highest risk alcohol and drug abusing mothers. And the purpose of the program is to prevent future births of alcohol exposed children. We're just going to briefly kind of touch on it because often when we talk about mentorship we sort of miss the history of PCAP. 3 programs in Alberta started 10 years ago modeled on the PCAP program. One of my programs, the First Steps program in CSS, as well as Lethbridge, both of those programs are called First Steps. They began in December 1999. The McMahon PCAP program in Calgary began a year later, and in Lakeland in 2001.
That's correct.
Today there are many PCAP model programs across the country within Inuit First Nations communities, often funded through the First Nations and Inuit Health Branch of Health Canada. In Alberta, the 3 programs that I mentioned in Lethbridge, Calgary, and Edmonton are the most closely aligned, probably directly with the PCAP modeled program, but there are programs that are starting up all across Alberta. Some of the highlights to understand what PCAP is, what some of the principles and philosophy behind it is, that it's relationally based, which means that people work with people. Mentors work closely with their clients and understand that there are stages of change, that we work with clients where they're at. Motivational interviewing is a particular kind of philosophy, and it's an important theoretical framework for this work, which speaks to the fact that understanding that people are at different stages of being able to change. The PCAP model program and a lot of the mentorship programs recognize and respect people's strengths. Work with a harm reduction philosophy, which means we don't fire clients. I think they can fire us. We work from a sense of understanding that we are going to work with people no matter what, as long as they're willing and able to work, and we don't fire people from programs. They get to stick with us, and we stick with them. And the harm reduction philosophy means that we hope that people reduce their consumption of alcohol and drugs. That's not always about all or nothing. Focus of PCAP model programs is on family planning and alcohol and drug reduction or abstinence. Other strengths of the PCAP model are strong supervision model with individual supervision and weekly staff meetings. And there's a very strong research component that's been built into the PCAP model program. Several tools are utilized, such as the Alcohol Severity Index. So there's some sort of technical research aspects to the program. What's really cool about Seattle, Washington is they've got published research all over the place, really documenting how effective this model is. And mostly Dr. Therese Grant is a main teacher and trainer in the PCAP model program, and a major publisher in much of the knowledge and literature that's been published.
So I'm just going to talk a little bit about the Cross-Ministry Committee in Alberta and what that means. But before I say that, you can see that Dorothy and I are flipping through some papers, and you will receive handouts for this session probably by email tomorrow. So make sure that you have that information filled out for the sites. And we apologize that that didn't get out there beforehand. So some of the information that we've talked about will be available to you, so you don't have to write copious notes. But the Cross-Ministry Committee in Alberta is made up of 10 different government ministries and that oversee FASD for the province. One of their key responsibilities has been to establish the FASD service networks in Alberta. And their vision is that the networks will provide comprehensive and coordinated response to FASD. A full continuum of services will be available across the lifespan and will be respectful of individuals, family, and community diversity. There are now, I think, 12 networks in Alberta, and they all have to strive towards providing targeted and indicated prevention as one of the pillars, which is kind of beyond the awareness piece of things, really focusing on prevention. And this is where the mentorship to the highest risk women falls, and that we're going to be talking about today. The other two pillars that networks need to follow are assessment and diagnosis across the lifespan, making sure that individuals that have been prenatally exposed to alcohol have that opportunity for a diagnosis. And then, of course, following diagnosis, the third pillar is support to families and individuals, so that those individuals that have a diagnosis get the supports that they need to be successful in the communities. So there are a growing number of programs across Alberta, as Dorothy said, in all of these areas. And so it's quite an exciting time to be in Alberta, I think. And so we're just going to cover the programs that we know best, of course, and highlight a few of the other examples. But do you want to cover CSS?
Sure. Okay. One of the things that I find interesting about the Cross-Ministry Committee and some of the networks, just to take a step back and make a link with that, is that there really is exciting working together at a variety of levels. At the cross-ministry level is really folks working in government that are policymakers and now funders. At a network level, there are communities across Alberta that are working very closely together, and there are different partners that sit around the table at these network meetings, not only to decide about funding, about FASD programming, but really around assessing what a community needs are. And I find that really exciting, that it's also a model that works well with the mentorship model, is that this is very complex work and it requires all partners to be sitting at the table. And in part, one of the things I'd like to communicate today is how important you folks out there in video land are to this work, that you really are partners in the work, whether or not you are self-identified as in a mentorship program, or you're a child welfare worker or a teacher, or your students to be. All of us have a role to play around prevention of FASD and support for individuals impacted and families, and it's really work that is done best in a community setting.
I think, too, just to add to that, is that not just at a community level, but provincially we're pulling the programs together. So the PCAP model programs are coming together to learn from each other and to share and to help those new programs that are developing. And I find that really exciting opportunity as well. So anyway, Alberta is an exciting place to be for those of you from elsewhere. Move to Alberta.
Start things up in your own communities, too. Exactly. Actually, there's PCAP training happening next week. Dr. Therese Grant is coming in. It's very exciting. A lot of new PCAP model programs. Some of the frontline workers are going to be going. The first training that happened in a non-Aboriginal sort of world happened about 10 years ago. Dr. Therese Grant came and trained First Steps workers both in Lethbridge and Edmonton, came together for a week of training. So First Steps started 10 years ago, December 1999. And it's interesting because actually the co-chair of our Edmonton network was one of the original mentors in that program. One of our funders actually attended that training 10 years ago, Dr. Joan McDaniel, who actually helped fund a number of our programs to get them going. So again, kind of an exciting, having funders attend the training to sort of understand the nature of the work was really exciting. So First Steps was our first program in Catholic Social Services, Edmonton-based FASD programs. Began 10 years ago with 3 mentors with 3 years of funding, and we found ongoing funding. The second program that started is the one that Denise actually was one of the original mentors in. Coaching Families began in, I think, December as well,
yes.
2001. Coaching Families is a bit of a shorter-term intervention program working directly with families who are raising children impacted by FASD. So we're working with the caregivers, not with the kids directly. And the purpose of that program is to support families to understand the nature of the disability that their child has, to help families access resources such as respite, to help families learn to advocate and work well with school systems and other systems that their children are involved with. And the families that we work with might be kinship families, they might be grandparents, they might be foster families, adoptive families, or birth families. I don't know if there's anything else you want to say about Coaching Families.
That covers it.
Okay. Step by Step is the next program that evolved from Catholic Social Services. And Step by Step really evolved out of some feedback from the experience of mentors in our programs where there was a gap in service for families where the parents themselves are affected by FASD, needing stronger supports and stronger connection to the community. Step by Step is loosely modeled on the PCAP program in that it also works for a period of 3 years with families. It's also relationship-based and smaller caseload because we're looking at caregivers who themselves are affected. The McDaniel Youth Program is our most recent program, started a year ago in July. This is the first time we have male mentors working on our staff. We have a total of 22 staff now. So we have in the McDaniel Youth Program 4 frontline mentors and 1 full-time supervisor, 2 working with male clients, 2 working with female clients. And we try as much possible to be gender connected so that the male mentors work with boys and the female mentors with girls. In this program, we work with youth ages 14 to 19 that have an FASD diagnosis. The kids, what we hope to do in this program is again in a 3-year-long model to really support youth to make a more successful transition into adulthood. This is a really risky time period. Kids with FASD youth often might be developmentally at different stages, and physically they're exactly where they ought to be, and that can create for a whole heap of trouble. And the intention of the program is to support kids to develop positive life skills and to get steered into directions that will make the transition into adulthood more successful.
So the Lakeland Centre, so the programs that Dorothy talked about are in Edmonton, and the Lakeland is a geographical area. It's not the name of a town. And we're situated in northeastern Alberta, right up, nestled up against the Saskatchewan border. And we're currently located, our head offices are in Cold Lake, which is where we are today. And we serve an area that's about a 3-hour drive from one end to the other, and everything is accessible by road. We don't have to fly into any communities, for those of you that are sitting in Nunavut. The Lakeland Centre has been around for a very long time. As a committee, it started in the 90s. In 2000, we decided that we needed to provide diagnostic services so that we could help people to get the services that they needed. So we received training from Dr. Claren and Dr. Astley at that time, came back and started a community-based diagnostic team in 2000. When we went to Seattle, we learned that the diagnosis was for 2 people for the child that was being diagnosed, and the original intent was always that the mother would get some supports as well. And we heard that message very clearly. So when we came back from Seattle and started providing diagnostic services, we hired somebody to write proposals and were successful in getting a number of funding grants. And one of those grants was to provide mentorship to the highest risk women. So our intent was always that when we found women through the diagnostic services who were still in the cycle of having issues with substances and were still having babies, that we would be able to flip them into the mentorship program. We call our mentorship program Mothers to Be Mentorship Program, which is a little bit different than First Steps. And because it's rurally based, has some different considerations that I'll get to a little bit later. But so diagnosis is our primary work. We've now, over the years, seen about 250 children and about 50 adults. From there, every individual gets an outreach worker who helps them to follow through on the recommendations from the clinical diagnostic team. We also provide a summer camp that's new for us in the last few years for kids that have a diagnosis, and that's been very exciting both for the kids and for us as staff to see those kids having such a great time. We do a tremendous amount of training and awareness kinds of campaigns as well. So it's a full service center. However, the center is somewhat virtual in that everything we do happens in the community. The center itself is just a bunch of offices. We don't do much with clients in this particular office site. Everything happens out in the community. So that's kind of our work. The PCAP program, the mentorship program, started in Cold Lake and ran for many, many years with one mentor only in this community, because we were unable to get stability of longer-term funding to expand the program to other sites. It's pretty hard to make a commitment to women for up to 3 years if you only have 1 year funding. And so we just wouldn't do that. Thanks to the new network dollars, we've been able now, with the security of those funds, to expand the program to set for 3 other sites. And so we'll have 4 mentors serving the area. So that's very, very exciting for us to be able to finally offer that program to the other communities. So Dorothy, you want to cover some of the other programs in Alberta?
Yeah. I'm going to go off topic a little bit, or just kind of spark on something. Yes. One of the things that I think is really interesting and neat about Lakeland is the relationship to the Diagnostic Clinic and the intervention programs. And in Edmonton, in our programs, that has been such a crucial relationship with all of our programs on a number of levels. One of them is that a good neuropsych assessment is such a piece of gold around understanding a child and a family's functioning, as well as an adult, and where they're at. However, if it just stays on the piece of paper, it's not much good. That's where the intervention and the supports and the wraparound services are so vital for people to sort of gather together to support a family or to support an individual, and really look at what's going on and what are their strengths and where do they have difficulty. And they're often very detailed. Capacity to read might be great. Their capacity to verbalize might be really impaired. And because FASD is such an invisible disability, I think it's really important to have that kind of relationship. In Edmonton, we've been really blessed to have a diagnostic clinic out of the Glenrose for a number of years, predating our programs. And the clinic was really vital in helping advocate and support funding and the development of a number of mentorship programs in Edmonton, including ours. And we've really worked hard to maintain a very strong relationship with the clinic. All of our new mentors, as they're getting trained, will spend time in the clinic to go through the experience with the family, to understand how it works, and to get to know the clinicians and the people that are part of it. And also for folks in the clinic to get to know the richness of our programs and what we can offer and where we're at. So that's been a really kind of critical relationship and very important. There are mentorship programs, of course, all over Canada, which Audrey will get to in a minute. And all over Alberta as well. Some of the ones that we've mentioned already are the McMahon PCAP program in Calgary, which has expanded to also offer a mentorship program for women who themselves are affected by FASD who are parenting with a real strong parenting focus. That's like a sister program to our step-by-step program.
And that's in Calgary.
That's in Calgary. Bosco Homes in Edmonton has the Open Arms program, which again works with women with FASD themselves or suspected of having FASD. What's interesting actually is to understand that it's really important that mentorship programs work out of a context of what's happening in your community. And so in Edmonton we've had the grace of a diagnostic center for kids and adolescents for a long time. And so we can almost require in some of our programs that there be an FASD diagnosis. That's not so for adults. It's been very challenging for us to get adult diagnostic services in Edmonton. And so as a result, when we offer mentorship programs to adults who we suspect of having FASD, we're very flexible about not having a diagnosis or because people simply can't access it, and it's unethical to offer services when it isn't possible for people to meet the criteria. So there has to be flexibility. Bissell Centre in Edmonton has had a number of FASD programs for adults affected by FASD, as well as a PCAP model program. Catholic Social Services has had FASD programs in Wetaskiwin and Red Deer for a number of years as well, and Lethbridge and Calgary have the PCAP model programs. Hinton and Edson FASD Committee operated a youth mentorship program for a number of years that has been flexible in terms of services. In Edmonton, the programs that I've described at Catholic Social Services, which are of course just one of many mentorship programs offered in Edmonton and area, kind of has sort of specific sort of areas. We have the youth, mentorship program working with youth affected. We've got step by step. We've got the PCAP model program working with women with addiction issues, and we've got coaching families. In rural areas, my suspicion is that the mentors are going to end up working with a whole variety of families and folks that, you're not going to have individualized kind of programs.
Sure. Across Canada, there are a variety of different kinds of mentorship programs as well. And I'm just going to run through them very, very quickly, just so you get a sense of what's happening across the country. In BC, they have a really great pregnancy outreach program that works with women who are at risk and it works with their families. It's not a PCAP model program, but it certainly is very close to that in an outreach capacity. BC also has the famous She-Way House that works in a facility-based program that helps women who are substance using and pregnant. Saskatchewan has no PCAP type programs, but they are working on some mentoring programs with families, supporting families, and they have a very strong parent organization in Saskatchewan, one that I envy actually. Manitoba has had PCAP model programs for a number of years, and I think they have 6 different sites now. They've been operating since about 2002 or so. They also have in Winnipeg FASD Life's Journey, which provides a number of different kinds of mentorship programs. I'm most familiar with the ones around working with the youth, and they have having some really great results there. As I understand it, Ontario has no PCAP model programs, but Toronto does have some programs working with high-risk women who are pregnant. Again, Quebec has no PCAP model programs as I know it. The Maritimes, I'm not aware of any PCAP model programs, but I know that there's been significant interest. And the territories don't have any PCAP type programs, but they do have some really successful mentorship programs with adults through FASD in the Yukon. Now, across Canada, in our First Nations communities, First Nations and Inuit Health Branch has been promoting the PCAP model program, and so across the provinces, they are sporadically available in the communities that are ready and able to deliver that service. And that's a really great opportunity for us in the provinces to link with those programs because they are developing some really great skills that we can tap into. And certainly, so this is a new and developing area in North America as a type of prevention program. Even though it's support to women, it's really a prevention program for future births of kids with FASD that is very successful when delivered in a non-judgmental and very helpful manner.
What is a mentor and what do they do? I think there's always a component of home visiting, that the work takes place in the community where people are comfortable. For some families, that might be meeting at Tim Hortons. For some folks, it's literally going home and having a meeting.
I think it's intense home visiting because lots of our women don't have homes to visit. So it's not your traditional kinds of home visiting program. It's a much more intensive home visiting program. But there is that element of going out to where they're currently at. I wouldn't necessarily call it a home always.
Yeah, that's true. Yeah, about most of our First Steps clients coming into the program are homeless at this stage. In other programs, Step by Step, typically people do have a home, although it's often a little bit tenuous. Coaching families, the families we work with, are often more middle-class families, so it's a really different kind of piece of work. And the McDaniel Youth Program, we meet kids where they're at. Hopefully they're not homeless. An element of mentorship is that we will drive clients to appointments. And this is a really key element. Often in agencies, there's risk management stuff about driving clients. This is a really key component that's kind of not negotiable. It's really important. When you're talking about clients that are beginning to engage with people and trust them, having had life circumstances that are incredibly difficult and challenging, the capacity to support clients in a very meaningful way means driving them and their kids to doctor's appointments, helping them access prenatal care, very, very sort of practical.
I do have to jump in here and just say that at Coaching Families, we don't drive our clients because they typically are more of the middle class and stable, but it's the other programs that do a lot of the driving.
Mentorship programs and what mentors do, they have focused, achievable goals to work on with clients. Often it's very crisis-oriented to begin with as people come into the program. Often we're talking about finding housing, getting children back from the care of child welfare, find income supports to access alcohol treatment programs. Very, very basic stuff to begin with, for sure. There's actually, I found a really helpful definition of what a mentor is from the Lakeland Centre, from a document that they published in February 2005 called the FASD Mentorship Inventory. Contact Audrey later for a copy.
It's on the website.
Yeah. Okay, there you go. Their definition is it's direct one-on-one support and advocacy to help clients address negative environmental issues in their lives by connection to needed services and assistance with following through on recommendations. The client may access services in central location or be served through outreach. Another sort of focus around mentorship is the long-term plan is to help women and families get their lives on track with or without their children. And again, this is a really key component, is that this program does not let go of our clients because they don't meet kind of our definition of what should happen. We work with them no matter what happens, whether they have their kids or they don't. Other programs will work with troubled families only when their children are in their parents' care, but PCAP and other mentorship programs work with women regardless of what their circumstances are. Caseloads typically, I think in Audrey, my experience is 10 to 12. Less if the individuals themselves are affected or impacted by FASD, because it's a little bit more work, right?
Just a little.
Some of the work that mentors do are to connect their clients with community services. So that's a lot of you folks sitting out there. To advocate for these services, that might include addiction treatment, mental health services, reproductive health, very key component, general health services such as prenatal care, getting kids to physicians, dealing with bed bugs, dealing with scabies, all kinds of sort of health issues that might come up for families, dealing with legal aid. This is a key component in especially our kind of PCAP model programs, is that a lot of our women come with messes that need to be cleaned up, and that includes trouble with court. And so a lot of our mentors spend time in court. And again, this is another sort of risk management issue sometimes for agencies. This is the nature of the work, and we need to support our folks to go there with our clients. Housing and shelters and things like that. I think ideally that connection to community services is really key. And when you're talking about sort of direct service to clients, we're talking about mentors accessing supportive relationship with children's services, dealing with addictions treatment. When mentorship programs have been around for a little while, and when there's kind of a capacity that gets built up in a community, ideally what happens is that advocacy can happen at a larger level. And in Edmonton right now, with the Edmonton Fetal Alcohol Network, we're looking at issues around, more systemic issues around addiction treatment resources and mental health resources for women. And we're going to gather a community of people who serve our clients to talk about what do we want to tackle in terms of changing the world, in terms of sort of a larger advocacy role. And again, it's an example of why it's so important to have that sense of a circle of influence around our clients, that we're all working together for the same cause. We all have often kids in schools and families that we engage with, that we need to work effectively together.
I think one of the things that highlights that for me is that recently we have a mentor that's been working with us for about a year, and in doing her evaluation just recently, she said she didn't realize how hard this work was as a mentor, and that she had always been on the other side of the fence as a foster parent, looking at the moms and wondering why they couldn't kind of get everything together to get the supports that they needed, and realized through this last year that often it's not the women themselves that are the barrier, it's the services that are the barrier, and we're trying to assist and advocate women through that process is extremely difficult. So just as a caution, it sounds so easy on paper, but it's a very difficult thing to support women through all these different services.
Well, I think as mentors, I think that we love what we do so much that sometimes it just comes out, well, I just support women through the process. I don't know how hard, and it sounds really easy, but I think that sometimes we carry a lot of that stuff around with us, and it gets to be really hard. But trying to explain it to someone, it doesn't come out the way,
yeah, that's right.
like how intense it can be.
Mm-hmm. Absolutely. There's actually, I think I want to share a story from one of our mentors in Step by Step from a few years ago, and this is something she talked about, that in Step by Step, mentors work with families where the parent has FASD themselves or is suspected of having FASD. And she talked about some of the issues are complicated by poverty, spousal violence, or separation and mental health issues. Of course, adults with FASD, most of them have what we call secondary disabilities, and that includes mental health issues. A lot of adults with FASD are depressed. A lot of them are at risk of suicide, suffer from other sorts of concurrent mental health diagnoses that make their lives very complex and challenging. And it also makes it very challenging for us to sort of access systems, and mental health supports can be very, very challenging. Lack of resources or understanding of available resources for individuals affected by FASD. Our step-by-step clients often lack day-to-day living skills, and sometimes have excellent ones. Like it really depends on how you look at it.
They're survivors.
Exactly. That's exactly right. There's a client that we have in Step by Step that is brilliant at understanding what FSCD will cover, which is Family Supports for Children with Disabilities. And it's another very helpful system in Alberta to support families with kids with a number of different disabilities, including FASD. This client has figured it all out. If I want to know what summer camp is covered, I'll give her a call. She's got it figured out. Clients with FASD and Step by Step, this mentor talks about the failure to predict when things are going to go wrong, resulting in involvement of the police or family services. And just kind of, I suppose what you would call an executive functioning disability, that kind of understanding what stress might be is just kind of placed in a place that the rest of the world doesn't recognize. So what might be not stressful for us is stressful for a parent affected, and what should be stressful is not.
Yeah.
Often our clients suffer from social isolation, and this is very true in our First Steps program too, a feeling of loss and grief, something I think that is common across the board for all of our clients, in coaching families as well. FASD is something that often has grief and loss associated with it, uncertain futures and fear of events that they have no control over. Frequently, with parents with FASD, their children can outgrow them developmentally, especially if they're not affected themselves. And their parenting skills make it difficult for them to understand and accept their child, but also hard for the child. And so in Step by Step, we really work in a more comprehensive way with the whole family. We work with the kids, we help support the kids, We're often, like First Steps work, we're going to a lot of attendance board hearings and supporting families around disrupted school experience and things like that. And then the last thing that this mentor talked about was that a lot of our families have burnt their bridges with other supports because they have challenges that are very frustrating. And that's why it's so important for the supports around families that are impacted by FASD to have an understanding so that those supports can be enriched and supported. Otherwise, you can burn those bridges.
This might be a good place to have Denise talk about the day in the life of a mentor.
I laugh when people ask me to describe the day in the life of a mentor because I don't think there is a typical day. Is there a typical day?
I did the same thing.
What does a day in the life of a mentor look like? You know, we have every mentor has a plan. They have their daytime or they have their list of appointments. But inevitably, you're going to get that crisis call. I was talking to one of my staff the other day, and she got a call from a client who said that she hasn't had contact with for a few weeks, of course. And this is a step-by-step client. And the mentor gets a call from the client saying, you have to come today because I'm getting evicted this afternoon at noon and I have no power and I have no gas and everything's being cut off and I don't know, there was probably another 5 other issues that she had to deal with, of course. And so you have to kind of talk to the client, get a sense of what's really going on because sometimes you don't get the whole picture, you get their version of it. And then she needed to take the time and start making phone calls to figure out what is the real story. Is she getting evicted as of today, or does she have a bit of time? And how much time does she have, and what can she do to get things in place? So she worked very, very hard, and luckily that client was able to stay in her own home, and they worked over a bit of time at getting her utilities and stuff back on. Another day, this same particular mentor happened to be out on training, and I get a call from one of the clients that is her client in a panic, telling me that her kids have just been kicked out of school, and this is the end of April. Her kids have been kicked out of school, and if she doesn't get them into a school today, Children's Services is going to come and take them away. So I had to do some talking and calm the client down and saying, you know, Children's Services is not going to take the kids away today. They need to give you time to find a school. And got her calmed down, but in talking to the school, we discovered that, no, the kids weren't really kicked out of school, but what had happened was that they were in a homeschool program. They weren't doing the work because, of course, mom wasn't able to monitor and make sure that they were doing the work. And so when the homeschool staff came out to the home, there was a discussion about the fact that the kids weren't doing the work, and so in September the kids would no longer be allowed to be in that particular homeschool. They would have to find another program to go into. Mama, of course, got frustrated, took all the materials, threw them in the garbage, and said, well, that's fine, I'll just take them out of school now. So those are just a couple of examples of what some of the mentors go through. I think one of the biggest things for the mentors is developing relationships with their clients, and I think that's the most important thing that we can do. And I found that in both of our programs, in both Step by Step and in coaching families as well. And I always think of one of my staff have a client who, she's been working with her for about 1.5 years now. And the first little while, I had gone to a couple of case conferences with my staff and the client with Children's Services. And so I got to have a little bit of a relationship with that client, not a whole lot, but a little bit. But the mentor had worked weekly with this client, and summer came along and the mentor was taking a couple of weeks off to go on vacation. And she had talked to all of her clients and said, you know, if something comes up that you really need help, call Denise. And so about 3 days after the mentor had left on vacation, I get this call from this particular client. Denise, I need to set up an appointment with you. I'm like, okay, fine. When do you want to meet? We decided to meet at Tim Hortons downtown. So I meet her a few days after that, and we're sitting there and we're having coffee. I buy her coffee. We're chatting away. And about half an hour into the meeting, she's telling me all these things that I've heard before from the mentor numerous times. They've talked about it numerous times. So finally I said, so is there a particular reason you needed to meet with me? She was like, no, I just needed to meet with you. I've been meeting with my mentor on a weekly basis. I needed to continue that. And I thought, wow, that's pretty powerful. That was, yeah, that consistency was really important. And it was really neat that she had such a good relationship with that mentor, and just those few little times that I had seen her that she felt comfortably enough to meet with me and just to chat. So that was really neat. And as a mentor in coaching families, that relationship building was also really important too. And I know in coaching families what we do is we spend the first 3 or 4 meetings just talking to the family and getting to know them and getting to understand the child and what's happening in their life. And I can't tell you how many times after about the 3rd meeting or 4th meeting, the client would say to me, wow, you've made such a difference. And I'm like, I haven't done anything. I sat here and I've listened to you. I'm like, what did I do? Finally one day I said, what have I done? Because I really haven't done anything. I've asked you questions and I've made a whole bunch of notes and I've gone back to the office. And they're like, you're the first one that sat there and listened to me, understood, and hasn't judged me. So that was really powerful. Yeah. So I'm sure Tracy has some stories to tell.
I do. We talked about this a little bit yesterday about what I was going to say about a day in the life of a mentor, and the exact thing came out of my mouth is there really isn't a day in the life of a mentor. Like Denise said, we plan, and a very intelligent psychologist once said to me, man makes plans and God laughs, because we make plans for a day and then I come in and turn my phone on at 8:15 in the morning and I have 13 messages from a particular client, and then the phone starts ringing and she's on the other end of the phone that her and her husband have had a huge blowout and I need to come and get her and he spit on me. And so I say, okay, what is going on? Well, he's abusing me. I ask if he's there, and if he's not there, then I will go get her. And I did go and pick her up and took her to the shelter, stayed with her through the intake process. And she said, okay, now I'm tired, you need to go and come back later. And so I go back later and I get them to open the door at the shelter, and they say, she's gone. She called her mom to come and get her and take her home. And that's a common occurrence, and I just have to roll with it. There are days when I schedule a day in the office to do paperwork and I'm out putting out fires, or I schedule a day with 4 different clients for home visitation and I'm dealing with whatever crisis happens to come about. But I do have clients that it makes me happy to be with them on a regular basis, and in the same way that Denise said, where they get so comfortable with me and with us that a particular client will come in here and say, I just came, I brought my lunch, is it okay if I sit and have lunch with you guys? Mm-hmm. And that is huge for us. It's a huge trust and a huge amount of respect. She has come so far and come through so much. And just to add a couple of things to some of the stuff that we deal with on a regular basis with our clients, Dorothy went through that list where we talk about the things that we kind of have. They come with these huge bags of problems, and we have to kind of sort them out and deal with them in an organized manner. The huge thing that I'm dealing with right now in our area is no-show fees. Clients who don't have transportation, make appointments, don't contact me, and then aren't able to get to these doctor's appointments, and then they have to deal with the no-show fees, because then they have zero health care. Mm-hmm. And so they place this huge burden on the emergency system. And then I have to deal with the emergency department on, why don't you see your own doctor? Well, how about you give us the money to go see the doctor, and then we'll go see the doctor. And the thing about court, sitting in court every week, is that oftentimes our clients will get into trouble, but they don't want to tell us they're in trouble. Mm-hmm. And so we go to court every week and sit there and find out that our clients have been in trouble again.
We often worry when we lose contact with our clients because it typically means that something has happened and there's going to be a mess to clean up.
Yeah. And I mean, that's another thing that comes up, is that we have clients who leave the program or don't tell us that they're leaving the program. They just kind of disappear, and that has to be okay for us. We can't take it personally. And then and this happened this week where a client just showed up out of the blue after months, and now she has a new baby, and it's not her baby, not her natural child, but she does have a new baby. So that puts her back into that whole 3-year cycle again, and we have to deal with what's going on with that baby.
A lot of times too, especially in first or in step-by-step, and I'm sure in first steps too, but because the clients are affected by FASD themselves, there's a lot of no-shows. So you'll go out to a client's home, and it doesn't matter if you phoned in the morning at 9 o'clock and phoned again half an hour on your way out the door. You get to the house and nobody's there, or they don't want to talk to you that day. And we have to be okay with that. That's okay. That's fine. We set another time. Try again the next day or the next week.
Right, but we also have to be okay with showing up to a client's home who's having huge addictions issues, and we show up to take a client to an appointment, and that client is under the influence. We have to be okay with that. And we have to be okay with rescheduling the appointment for another day. And it's not, for me, personally, it's not okay for me to stay there while that client is using, or not okay for me to stay there while that client is hugely drunk. I make sure that she's in a safe place. Are you safe for today? Okay, I'll be back tomorrow, because it's not okay for me.
Right.
So
sometimes I think we have to reframe what we think a success is. And I'm thinking about a First Steps client that we managed to get to Beaver Lake, which took a bus ride, which meant getting funding for that. And they lasted 4 hours. And kind
it was
of
4 hours.
Exactly. Now
4 hours longer than any other time.
The second time they made it to Beaver Lake for treatment, they lasted 18 hours. Now the treatment center thought that was a huge issue, and it is. There's resources, but it was a success in some ways. It was 12 hours longer than last time, or 14 or something.
But sometimes for me, the success for that particular day is that client got out of bed and phoned me, because oftentimes 90% of my caseload is are affected women, and so for me, circadian rhythms and sleep issues are huge. And so if a woman can get out of bed and call me in the morning and say, "Hey, how are you? I got out of bed today," that is a huge deal. Huge deal.
I always tell the mentors that it's not a short race that we're in here. This is a long distance process, and it takes a long time to get things back on track where they need to be. But I think the success of the program is that it can be done, and by hanging in there and being consistent and always being there is huge for these folks. And often they're used to systems that let them go after they push back a little bit. And so when they find out that they can't really do anything to prevent us from being there to support them, then we start to see huge, significant changes. And I thinking about a fellow that we worked with, and we diagnosed him in his late 30s, and he had always been in and out of jail, and we happened to actually diagnose him while he was at the Remand Centre in Edmonton, and the longest he'd been out of jail at any particular time was about 3 weeks. And not that he'd done any heinous crimes, it was always just really silly things. But once you've been to jail once, you don't get that nice probationary card, you automatically will go back to jail. And we had a hard time connecting with the justice system to find out when he would be coming out of jail in order to support him. So but after several years of working with this gentleman, we've been able to keep him out of jail for a couple of years now. And the last time he got into some silly trouble, he was able to do his time in the local jail on weekends because we were there to support him. And one of his probationary measures was he had to describe to the courts his life, what that was like. So we gave him a camera, he made a big poster. And the thing that I will always remember is he made us take a picture of him under the sign on our building, and he wrote on it, "This is my center." And I think that, that after so many years of him being into trouble, that he's able to identify us as being helpful and supportive to him. But that was a long road. That's been at least 5 years for us to be involved with him to get him to that place. So it is help. It does work, I think, is the key message.
And I think because we come from a place of love and respect and non-judgment, and it's okay to fire us, but we'll be here when you come back. It makes a huge difference. Women come back for longer and longer periods of time. And I know we make it maybe sound easy when we're kind of talking about it, And I guess if you're coming from a place of love and non-judgment, that part's easy.
I'm thinking of some other success stories. In First Steps, you get to attend to a lot of births. And I remember Liz, one of our mentors, talking about how moving it was for her to be the only safe person to be present at her client's birth, because the rest of her family were using, and it didn't feel safe for her to share that experience. And I think that's a kind of lonely experience for mentors sometimes, to be witness and to sort of travel alongside of people's lives in such kind of significant places. To give birth is such a sacred opportunity, and it often is kind of overlooked. One of the groups that in Edmonton that we've had the pleasure of working with is Basically Babies. This is a lovely group of women that have put together these beautiful hampers for our women who give birth, because there's nobody there to celebrate. You're a mom, and this is really special. And so they get these absolutely gorgeous hampers with brand new clothes and handmade quilts and many, many sort of things like that. And for our clients to have their children and their kind of identity as mothers to be honored and cherished in that way is such a meaningful thing. I'm thinking just two other quick stories of a First Steps mom, several unbelievable sort of success stories as well, where people have really gotten their lives together. One of our moms successfully gave birth to a child and chose adoption, chose to have her son adopted out, and is very successfully working in a northern community in a helping profession, which is just amazing, make those choices. And I'm thinking about a step-by-step family where just an unbelievable mother, just very, very competent with 3 children, herself affected, came to us at a stage in life where she was fighting a lot of systems to get disability sort of supports for both the physical disability as well as for the FASD. And we could not access funding for the diagnosis or for the assessment, and it was very, very frustrating. And finally our agency sort of came in and chipped in a couple $1,000, and Val Massey cut her fee in half for us, and we got that assessment, and that assessment made such a huge difference in that woman's life and that family's life. As a result of that assessment, she was able to successfully win a CPP disability appeal, and so her funding was completely reassured, a lot better than it had been. We were able to support her to sort of maintain her housing. She had had some issues with some drug-dealing neighbors that, was just very difficult. And we were also able to successfully support this family for all 3 children who had been prenatally exposed to alcohol to have an assessment. And it was a really positive experience. 2 of the 3 kids ended up with the diagnosis, and 1 of them didn't. But in all cases, the clinic celebrated what a fantastic parent this woman was. And it was really neat to sort of have that experience where in both cases, regardless of the outcome of the assessment for the kids, that her capacity as a parent was really celebrated.
Would this be a good place for me to talk about some of the rural challenges?
Sure.
Many of you will be working in rural communities, and I can see from some of the screens where some of you are at, not all of you, but so I know that in smaller communities, it can be both a pro and a con to have these kinds of programs. You often don't have the confidentiality that you might want, because as a mentor and working for a center like this, people are going to make some assumptions about who your clients are. And that might be good, or it might not be good. So in the good sense is that sometimes people know who the mentor is, and so when she brings a woman to the emergency room because she's reached that stage where she wants to make a change in her drinking or her substance use, the emergency nurse may know exactly who the mentor is and avoid the embarrassment for that woman to have to sit in the waiting room and usher her right into a stall to see the doctor right away. And so that can work really for you. In other situations, you may only have one employment officer in your community, and if they're particularly grouchy, you don't really have a choice but to kind of deal with that and work with it and try to to do the best you can for the woman that you're working with, or the client. So I think those things can both work for you and against you. There's certainly also that you need to work out as a supervisor issues with your mentors about how they're going to handle situations when they run into their clients in the grocery store while you're taking your children to the movies or just regular activities out in the community, and how do you handle that? And so I think that that's really important, because sometimes our clients don't have good boundaries, and so they start to tell you in the grocery store lineup their latest episode or problem, and so, you know, those of you from rural communities are probably smiling about that. Those of you from the big city who get to go grocery shopping unapproached, good for you. I'm so envious.
Or alternatively, if you discover that a client you've picked, you know, that you've taken off the caseload lives across the street, we can assign them to a different mentor. And
Right.
rural areas don't have that grace.
No, we don't have that luxury. So it can work for you and against you. I would recommend that in smaller communities that the supervisor pay particular attention to these kinds of issues and really allow a lot of opportunity for mentors to debrief. It's really important that they have that opportunity to blow off steam about that grouchy EI worker, or because that's the only game in town, we have to find a way to deal with it. And many times, as I think Denise said, that many of the individuals have burned their bridges already, and so I remember one situation where we had a woman who was very, very difficult to work with. Whenever she went to a government office, they would immediately call the police because of her erratic behavior. And because they did that, that escalated her behavior, and so it just went around and around in a circle. And so we now have that woman calmed down and supported enough that she can go to different government offices and not be called, the police aren't called. She can actually access services and get funding and all kinds of things. And we're actually looking at launching her into some volunteer work in the community this year. So, you know, but it can be really difficult sometimes. And you don't have another office to go to, so that's a problem. I would also recommend that in rural communities that you build a really strong relationship with your local RCMP office. Make sure that they know who the mentors are, and that mentors should use that as a strategy when they're not sure about situations to go into. Is this partner safe? And just letting the RCMP know they're very good in the rural communities of there's kind of a tight-knit group of social worker type folks and the RCMP that work together to make sure that everyone remains safe in the community. So I think that's pretty key for rural areas as well. Did I miss anything, Tracy?
I just want to jump in and say that the whole part about debriefing with a supervisor or other staff is crucial no matter where you are. It's something that we do in our programs all the time. If a supervisor isn't available, staff will debrief with each other. And you need to have a really strong team to be able to be comfortable in doing that and safe in doing that. But it's such a vital part of the work.
Yeah, absolutely. It's true.
I think paying attention to vicarious trauma, which is a fancy word for we witness things on a day-to-day basis that can accumulate, and it becomes very distressing, and you can lose workers over this. It's really, really important to have a supportive environment, to support each other, to recognize the impact that the stories that we witness, hard and good. Tracy, you were just talking about leaving a piece of yourself sometimes.
I believe it's been my experience in the last 5 years that every time when we have a meeting with a client and she shares something horrific or even good, when we leave a piece of ourselves behind, and they leave a mark on our lives, and we have to be really, really careful that we don't carry around everybody else's stuff, because that leads to some burnout, and it's not fun at all. It leaves us wide open to everybody else's stuff too, even within our own team, because we've been so open for so long with our clients. All of a sudden, we're really open with everyone.
Dorothy calls that the bruising effect, and so we use that term a lot in our program.
The other thing that gets challenging, I know in our team sometimes, is because we're so closely aligned with our clients, we can get very angry with systems. and very frustrated. And I think that having negative experience with systems can have a bruising effect for us as workers as well. It's really huge to be turned down. You know, to have your client standing in a public place 9 months pregnant with an addiction issue being turned down by you know, welfare because you should be out working is just humiliating. And it's humiliating not only for the client but also for the worker.
But having them asked if this is the same abusive relationship they're leaving again in an open office.
Yeah.
It's huge.
Yeah. So it's really important to develop and talk about self-care strategies to make therapeutic supports available, paraprofessional supports available, to have an open environment as a team to support each other. One of the things I wanted to honor Lakeland and Tracy is the mentor conference that you guys hosted last year. It was just miraculous and wonderful. Very, very good. It was an opportunity for mentors across the province to come and get looked. Wow. How many people came?
100.
Amazing.
120-ish.
A lot of self-care stuff there. You guys, it was amazing. What did you all organize? There was like massage.
We opened with our self-care evening where we had mini massages, facials, manicures, really, really good food, and amazing opportunities to network and meet each other for the first time. And it really was a very an honoring experience for me and a humbling experience for me to be able to honor the women who do the same work I do. It was an amazing experience. We had a lot of fun.
That's awesome. And there's such a community of people who do this work, right? There's a piece of not really getting it until you've been in there and doing the work. Yeah. There's a real sense of community. I wanted to actually talk a little bit about advice from mentors from, again, the mentorship inventory that came out of Lakeland, because there's just a couple points here that I think are so true. And when I read them, it was like our guys talking about it, right?
So they probably did, because we interviewed a lot of people.
It was awesome. So this is what mentors said across country. First thing, forget what you learned in school. That's a good place to start. Expect anything and go with the flow.
If you expect the unexpected, you're never disappointed.
Right. And I think sometimes in our university training we're taught about different theories of practice, and those are all really important, but they don't always apply to this population of people. And so I think that's the part that you kind of need to forget about.
Adopt a can-do attitude. Provide whatever is needed, however it works, including use of outside-the-box methods.
Yeah, I think I know that the mentors that I've worked with over the years, and certainly the ones that I heard from at the mentorship conference last year, are very creative people in how they develop strategies.
I think one of my favorite stories is one of my mentors took a woman with mental health issues to the emergency room to try to get her committed because she was very suicidal. And guess what the intake physician said? Do you hear voices?
Fabulous.
And so the job of the mentor there was to zip her lips, because of course she hears voices. What kind of idiot are you? And it got her in, and it got her to get the needed resources. That's the thinking outside the box, right? Like, why explain FASD, blah, 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 blah. Do you hear voices? If it gets you in, honey, it works.
And sometimes I think in rural areas people are very creative as well, because we don't have a multitude of services to choose from. So you kind of make it work the best way you can. I call it massaging mandates to get the services for people that they need. But I'm just thinking outside the box. Probably one of the most unique things that we did with this program was right at the very beginning when we launched in 2001. We had developed our nice little brochures, all our forms. We knew what we were going to do. We distributed them to all the agencies and then waited for a couple of months, and there were no referrals. Not because there weren't any women out there, they just weren't within those agencies long enough for them to make referrals. So we were sitting there thinking, well, how are we going to connect with the women who need us when they're not connected with any of the services that can make the referrals? So we actually went, our mentor went and made friends in the bars with the local bartenders, as well as most rural communities have a bar culture. It's usually a group of older men who are in the bars, and we made friends with those folks and talked to them about what we were doing and over time what the program was about, and found out that many of the women that we serve go in and tell their problems to these men in the bar. So pretty soon these men were handing out our mentors cards saying, honey, you need to call her. And so that's how we launched the program, because we couldn't get connected to the women. And now, you know, it's better known and families make referrals. And so it's a lot better, but at the beginning you do have to be very creative about how you're going to launch the program. I mean, we could have just quit there. We could have said, oh, there's no women, there's no service, how are we, you know, and we could have stopped there, but we didn't. So
That's awesome.
I still put posters in bars.
yeah, for sure.
Very good place. This is a really important point, I think. Make no assumption about a client's, a community's, or other service providers' knowledge of FASD. Most are still at a basic level. A good deal of the workers' energy will be spent on advocating and educating others about the realities of FASD. I think that's extremely true.
We do that every day. No matter who we come across, you end up teaching them about FASD. No matter how many times they say, oh, I know all about it, you start asking a few questions and you're like, yeah, you need some education.
Or you get service providers who say, well, this client who has that diagnosis does things this way. Why won't that client do? And well, because they're two different people with, two sets of different capabilities.
It's interesting, when we first started, it was, well, what is that FAS stuff? And now there's a great deal of awareness, which is wonderful out there, that people recognize it. They can usually even sometimes identify it, but they don't know how to change their practices. So I think that's the stage that we're in right now in terms of helping systems change their practices and better able to serve these individuals. And so we do that client by client, day by day, and we do see a tremendous amount of progress. For example, in the school systems here, when we first started doing diagnosis, the school systems did not want to be a part of what we were doing. They did not think that FAS was a problem. And so after diagnosis with children, we had to really advocate to get into the schools, to even be invited to case conferences and things like that. And now, after 8 years, the schools call us and say, okay, because you guys have to travel to our school, we'll line up all the FASD kids on the same day so that we can see them all and get your input for them all in one day. And so that's tremendous growth. And so I think that all the other systems are certainly coming on stream as well. So I think that's the phase that we're in now.
Success will depend on how motivated your clients are to change. I think there's truth to that.
Yeah, I think that goes with the last one. Do not work harder than your client.
Yeah.
Well, and I think some success is also dependent on how well the mentor maneuvers the client as well. Because sometimes it takes some maneuvering to get that client to a place where she's willing to be motivated. Because some of them are not willing to be motivated to change. Or able.
Well, yeah, I was going to say or able, because a lot of clients have the motivation to change, but they don't know how to change, and they don't know where to start, and they don't know how to continue things on. They know what they need to do, they just don't know how to do that.
The other sort of piece of that, I think, is our assumptions as workers is to become aware of that, is that our egos get tied in this work, and when there are challenges, we can get frustrated with our clients. And I think it's always about, the image for me about working together is to be side by side and not pulling too much and not pushing too much. That there's just a sense of being in step with your client as much as possible about where they're at.
And not to be disappointed.
Exactly.
And don't take it personally if they fail, or if something goes sideways and things don't work out the way we think they should work out. We can't take that personally.
Which also means to grieve our losses too, when things don't work out. Yeah.
So other advice for mentors?
Keep it practical. Deal with poverty first. Put aside the program's agenda until basic needs are met. I think that's really true. And I love this last one. Be well informed about trauma, addictions, mental health issues. These are really key pieces of the work, and I think key sort of systems areas to work together as well.
Yeah, training's a huge part of what mentors need to do before they even get a caseload, I think. Yeah. All right. So do you want to flip back into we kind of skipped over the credentials of the mentors, who they are. Sorry, as we flip through our notes.
So mentors for us and Catholic Social Services, and really I think very typical across the board, is we require, and there are employment realities that have been very challenging in Alberta, in that we've been in a boom culture for a while, and it's been challenging to have, what would you say, competent salaries to sort of get people. It's been challenging. But our mentors have a minimum of a 2-year post-secondary something, usually a diploma or degree, 2 to 4 years or more. We also require at least 2 years of relevant work experience in a related field, and that's pretty flexible. We will also take people straight out of school that are willing and open to work and learn.
Yeah, and in our programs in a rural area, we hope for 2 years of post-secondary, but we put more emphasis on life experiences and look for about 5 years of experience working with at-risk populations, and then we do a tremendous amount of training on the job. We don't even give people a caseload for 4 to 6 weeks. They have to do training, shadow more experienced mentors, and just get a sense of the overall organization and the role of the job.
That's key for us as well.
Yeah, we do a lot of job shadowing.
And a lot of training, sort of formal. And I suppose that's another challenge around rural versus urban, is that there are more training opportunities.
It's getting much better now that we have the opportunity for video conferencing, but we do a lot of our own in-house training, so and we train each other now that we have that expertise.
And key areas would be grief and loss, self-care, clinical sorts of development of skills, learning about addictions, motivational interviewing is really key, ethics, professional boundaries.
Mental health, first aid, yeah.
Exactly.
And universal precautions.
Exactly. That kind of safety piece is really key around HIV, and like our clients have communicable diseases.
No.
It's important to be, yes.
Our clients? No.
Yes. And again, the lots of training on the job and buddying up. And what we found in our programs is that initially we did that buddying up in order to train people, but what we found is really helpful is to have a second mentor that actually knows your caseload. So when you do go on vacation, that there is kind of adequate backup. So yeah.
We found that before we were doing that, especially in coaching families, that the mentor would go on vacation and would tell the clients, if you need anything, phone this particular person. And the other mentors who were backup would always phone and check in with the clients. And usually you got the answering machine and you left a message and you never heard back from them. And then the mentor comes back from vacation, goes to see the client, and there's all kinds of issues. And they're like, well, why didn't you call the other mentor? Well, because I just wanted to talk to you. So that relationship with the second mentor has been very, very helpful.
We're looking forward to having that opportunity.
This will be new for us.
Yeah.
Great.
What makes this work successful? We've already talked about a number of different kinds of things, but certainly there was a state of evidence review of FASD prevention by Brasford in 2004 around the characteristics of a successful program. And so some of those were intensive levels of service that is responsive to client's growth. So we've kind of talked about that being very client-centered and being able to identify client need and growth. That it's relationship-based, that trust is gained, and workers have perseverance. And we kind of talked about this a little bit, but really these mentors, that is a key characteristic that you want to look for in hiring new mentors, is that they can stick with it through the good and the bad, and I think that's one of the things that we certainly look for when we're hiring. Mentors are role models. This is really true in rural areas because you do see people out in the community. So for example, Tracy and I don't drink in public, We may have a social glass of wine someplace, at a fancy dinner, but we don't go to the bar and drink. We leave that for when we leave the community or go on holidays to Cuba. So not that we're the alcohol police, we're not, but we really want to set a good example for the people that we may run into while we're out in the community, and as well as around our other sort of health habits. So that we can share those with the women, because it's a small community, and really everyone knows that Tracy goes to Weight Watchers. It's just a fact of life kind of thing. So, and now all of you know, and she's going to kill me later.
Successfully.
She's going to kill you.
Yeah.
Totally.
So other successful key things were work is strength-based. So that's, we talked about that, and non-judgmental. And this is really a hard piece that you have to grapple with, and partly why we don't also give mentors a caseload right away is because they need to figure their value system out and how that's going to relate to the work that they do. And so non-judgmental, it's easy to say. It can be quite difficult because it's amazing what you bring of your own personal perspectives to the job. One of the very first mentors that we had was someone who was in recovery themselves for a many number of years, and she taught me more about addictions than I ever learned in a classroom. And I was shocked at some of my own stereotypes that I had, bought into, that I had to deal with as a supervisor. So we all bring our own personal biases to the table, and we really need to figure out what those are. And I think client and family focused, which is pretty clear, and helping the client to find and keep appropriate services. So once you connect them, that's not the end of it. You have to make sure they stay connected in a meaningful way to all of those things: food, shelter, safety, diagnosis, addictions, treatment, social services, legal supports, domestic violence, counseling. And keeping women, particularly the women we work with, connected to their children if they're in care. We talked about training, supportive supervision, and regular team meetings. Denise, do you want to talk about what you guys do in terms of supervision and regular team stuff?
Sure. We do a few different things, actually. I have regular supervision with my staff. When it's a new staff, I try to do weekly supervision, and when it's more seasoned staff, every other week, every 3 weeks. But my door is always open, and you start getting into something, you're working on a year-end report, and you're right into doing all the math, and somebody walks in and I need to talk to you. Okay, so whatever I'm working on always gets put aside to help the staff deal with whatever they're dealing with. So we have one-on-one supervision. We have a lot of just debriefing amongst the team as they come back from different meetings. But we've started something in the last couple of years, year and a half, where we've got all of the mentors. We have about 21 people in our program, 22 people in our programs now. And so we've divided them all into 2 groups, and we meet every other week, and we call it collaborative case consultation. We have one staff present about a particular client that they're working with and talk about how are they doing with it, what are some of the issues, do they need help with anything, and then we just sit there and brainstorm about try this, try that, maybe you need to connect them with this resource or that resource, and it has been an amazing experience. The staff are learning about other resources that they're not aware of because we get in our own little worlds in the different programs, and so the coaching family staff are able to offer different resources to the first step staff and vice versa, and it's been very, very helpful. And in addition to that, we have our regular team meetings to talk about more business stuff. But even at those meetings, we always try to set aside a little bit of time so that if there's an issue in regards to a particular client, we have time to talk about that.
I think the collaborative case consultation is great because we're utilizing the expertise of each of the mentors that they can offer to each other, and it also helps our teams be less isolationist because you can really get into the mode of nobody really understands my work, right, even when it's all the same. So we've made a real effort in our programs to work together and to really see our work as our work together.
The Lakeland Centre does a very similar kind of thing as well, and because we have a number of programs, we do have monthly staff meetings, but we have regular supervision for all the staff, but we have what we call team meetings, and we often integrate those as well. So that the adult services, the children's services, and then the mentor program do case consultations on a regular basis. And just as Denise said, the cross collaboration is really key because you're seeing different issues, and you maybe had a breakthrough in a certain agency. So those kinds of things are really important to know about. I just want to share an example of how you tie all the things together. And we have a woman that we will refer her daughter. Let me just start at the beginning here as I get all the pieces flowing through my mind in the right order. But we had a young woman who was referred to us for diagnosis. I think she was 14 at the time. And when we diagnosed her, we recognized that the family needed some additional support. And so she was connected to an outreach worker. The outreach worker recognized really fast that the mom of this girl was pregnant and using, and was connected to the mentor program. So now we have 2 workers involved in that family. Later, as the family dynamics have evolved, the young girl has got pregnant. And so we, as a young woman, she was 17, I think, at that time, and in a relationship, and so she was also connected to the mentor program. And so this often happens for us in that we're able to link all the programs together to either we find women in the program that need to have their children diagnosed, or we find that our adults need to be diagnosed, or that they need to be linked into the mentorship program. So we're able to catch whole families in this way, and that has been really successful for us. Creates some challenges for us in terms of confidentiality among programs, but certainly the ability to connect whole families. So we certainly see diagnosis as well as a form of prevention.
Mom was also came in for diagnosis.
That's right. I forgot that part. Mom also came in for diagnosis, and so that whole family has been collected now, as we say. But often when we diagnose children in families, the moms will tell us, I got to go tell my sister, my auntie, that they're pregnant, not to drink when they're pregnant, or that they need to bring their children to clinics. So we tend to work our way through communities and families as well. So I think that's just how the whole network thing can work really efficiently together.
We're finding that too with now that we have the 4 different programs. An example is that in Coaching Families, we recently took on a family who was having some issues with their daughter is affected by FASD, and there was some school issues that they wanted help with. So we went in there and we were working on that. And in working on that, we found out that power was being cut off, utilities were being cut off the whole the whole bit. And we recognized that the parents were lower functioning, and in doing the work we recognized that, maybe the parents themselves are affected, and they were giving us some information that led us to believe that. And so knowing that, we then opened up a step-by-step file at the same time, and we said, okay, we're going to have very clear boundaries as to what the staff are going to do. Step-by-step is going to work on all the housing and those sorts of income issues, and Coaching Families is just going to work on the school piece. But we've also got a lot of other families that are in Coaching Families that are now connected with the McDaniel Youth Program. And it's been really helpful to have those 2 workers in that same home. They are able to share some information, but we're careful as to what we share. And it's been a really interesting experience in the last year.
Yeah, it works really well when it works well. I just want to also, because from the diagnostic perspective, the importance of this kind of support program for women, in that we see that children that get diagnosed tend to come from families of at least, on average, 5 siblings. So that's on average. So we have women that are having 10 to 12 babies that are all affected. And so when we can link them to this program, and that's why we're so excited to be able to expand this around our region, to really be able to connect all of those women to get their lives back on track to prevent the future births, really makes a significant difference to those families and to society as well. So.
And I think it also speaks to the intergenerational grief and loss. These are not people that we get in contact with. They have generations of grief and loss issues that are complex, right? And in coaching families, we often have grandparents raising kids, and we need to work systemically and not just, I think Karen O'Malley speaks about this really, really effectively, that the trauma and the grief and loss is intergenerational, and I think it's helpful as workers to appreciate that we're not going to support things quickly. Like, it's very long-term kind of work, but very rewarding work.
That's right, and I think too, in diagnosis, we've diagnosed in some families back 4 generations. So it's fairly significant, intergenerational. Yeah.
The other thing I just wanted to add to sort of what makes the work successful and what's really important is also to give feedback to our staff around what we learn, and from the front line to give feedback around how we develop programs. Like, there's really important to have a feedback kind of mechanism and loop. The example I'm thinking about is we had a mentor that burnt out when all of her caseload finished their 3 years at the same time within a 6-week period. And it was just exhausting for her. And we began to recognize that having a mentorship program that has like a limited period of time has an impact. You develop these relationships. So it's important to sort of stagger the caseload from that perspective. We learned to do that. But what we also learned from that, we talked about it in staff meetings, is we learned to celebrate the year-long marker. So at every year of the 3 years, we really make a big deal of, taking the client out for lunch, and sort of really honoring what's been done and what's happened in that year, and to sort of utilize it as an opportunity to practice closure in a way. It's like a mini closure. Because otherwise, if we just sort of trundle along for 3 years, we traumatize our staff as well as our clients. And I think there's a huge benefit to having these markers to sort of celebrate what's happening as you go along, so it becomes a bit of a practice.
That's a good idea. Sorry, thought's gone. Sorry.
Oh, I had one other thing I just wanted to mention, is that we've been blessed with a good relationship with a number of researchers and have participated in our programs with some formal evaluations of the first 3 of our programs. But what's been really helpful and important about that process isn't just to hopefully publish papers, but to actually learn and integrate what we're doing in a way that we can learn from as well. So that feedback loop is really important.
Cool. How many women do you think you've supported in the program, do you know?
To date?
Yeah.
Probably 500 in first steps.
Wow.
Yeah. I'm thinking average caseload of 12, 6 mentors. Yeah,
Wow.
maybe
Yeah,
not that
I'm not
many, because
sure.
it's 3 years long. So yeah.
Yeah, we've not seen that many, but many of our.
I know this is just under 300 in our
Oh,
research study.
okay,
Yeah,
300. Oh, wow. So ours is probably less than.
It's like 30.
30, yeah, so somewhere in there. But many of our women, as Tracy said, are FASD themselves. That's not a criteria to get involved in the program for sure. But because they are, we tend to stay with them longer than the 3 years. We often stay with them up to 5 years unless we can transfer them to one of the adult programs successfully. But sometimes they're not ready to go.
in Step by Step, we've served probably close to 50 families, currently serving about 21. And in our research project with post data, we had 25 families. And in coaching families, we had quite a big data set, I think 400 or 500 there.
Yeah, I don't remember.
Yeah,
Wow,
and
that's
the
great.
McDaniel Youth Program's just starting up, so we have an average caseload of 6 or 7 clients and 3 mentors currently working, so 21 clients.
Wow.
Okay, we got a question that just came in. What's the average caseload per mentor?
My caseload fluctuates back and forth. I usually carry about 9. I have had as high as 14, which was the day I walked into Audrey's office and said, I can't carry 14 kids. Can't carry 14 people on my caseload, just can't do it. Because 90% of my caseload, because of the intergenerational issue with FASD, is 90% of my caseload is FASD. So it's really makes things that much more complicated. So about 9 to 11 is about the optimum.
And what the PCAP folks say is that if you have a client that you strongly suspect is affected by FASD, you count them for 2.
Oh yeah, sometimes 3.
Depends on the day.
So our average caseload would be right around there, 10 to
Yeah.
12 would be about average across all the programs.
Yeah, I think that's probably.
Yeah, I can say right now that both of the step-by-step staff have 9. And even in coaching families, it's really interesting because when we started in coaching families, our intention was to have between 10 and 15. And quite often we were running at about 12, 13 families. Our families have gotten so complex in the last 3-4 years that 10 is the maximum for our families.
For mentors,
For the mentors, yeah.
I wonder if part of that is that we've become better at serving families because we're working together across all the mentorship programs, that we're recognizing sort of things that we need to be recognizing.
Or the other part is that we've dealt with the more obvious cases, so now we're dealing with the cases that are more subtle and obviously more complex that have maybe run under the radar for a lot longer.
Yeah. Just because we're carrying 9 to 11 doesn't mean that all 9 to 11 are always active either.
Yes, exactly.
That fluctuates a lot,
Yeah.
and that's okay for me.
Friday before a long weekend, though, they'll all be active. You just count on that. Any other questions?
How do you access PCAP training?
Where's the question coming from?
It's an Alberta phone number.
Okay.
So.
Through their networks. It's being set up. It's by invitation to the networks who are developing new programs. So if your network should be connected to the information on that PCAP training. Outside of Alberta, you would need to access Therese Grant at the University of Washington directly.
Out of a sense of grace, I think we've coordinated PCAP training across Alberta, or it's in a coordinated place, which is really neat. And there's actually frontline mentors that are part of a committee that's organizing this. And so Therese is coming next week in training from Tuesday to Friday, which is really exciting. So there's going to be mentors from across the province coming to that. I suspect that there might be room outside of the province or country for that to be made, possibly. I don't want to offer that, but...
Well, and there was some discussion about doing this again in the fall.
And I believe that's planned. And there's also some discussion about the possibility of developing training capacity here within our province as well.
We're not quite there yet, but yeah, there's some discussion going on about that.
Mm-hmm.
All right. The information for the sessions is going to be emailed out, I believe, tomorrow. And Dorothy's and my contact information is on those sheets. So if you do have other questions, feel free to contact us, and we'll answer as best we can or put you in touch with the right people. So I hope this was helpful. It was fun for me.
Yep, really enjoyed it.
Yep.
And that information will also be on the CMC website. So if you don't have that, it's www.fasd-cmc.alberta.ca. And evaluations will be emailed out to everyone who signed in, and we get their sign-in sheet back. So if no one else has anything else to add, I will thank you guys very much for this presentation. It was really interesting and entertaining for me to sit here and listen to them, and hope we can do it again. I really like this format. So thanks everyone for joining, and we'll see y'all later.
Thanks, Erin. Bye,
Thanks.
everybody.
Bye.
Take care.
Bye.
Good luck.